discussion. Now, a nice lead-in as far as the A&H and all that with Dr. Earl Strum, who is our Chief of Anesthesiology here at CAC. He's also Associate Clinical Professor of Anesthesiology, Chair of our Transfusion Committee, and I think a few other committees that you might want to mention or may not want to mention. I'm sorry, Professor of, I looked at an old, Professor of Clinical Anesthesiology. So he's going to talk about the anesthetic management of the Jehovah's Witness patient. Many of you may remember a few years ago when he talked about a similar topic, but please introduce you to Dr. Earl Strum.
Thank you. Good morning. That was an excellent lead-in by Dr. Selby, by Rick. And some of the questions are going to be maybe a little repetitive or reiterated. And most of the talk, it's going to be interactive. So Rick was talking about A&H, so I'm going to actually show you how it's done. And we're going to see if we can avoid making a mess. I created blood this morning over here, and this stuff gets very messy with what I use. So we'll see if that works. So we can actually see a live demonstration of A&H in circuit. And I'm going to talk a little bit about some of the preoperative issues that we need to deal with before we do an A&H patient. The nice thing is about Rick's lecture, I was with him with a lot of those pictures over during those transplants, during the first cadaveric transplants. And I must tell you a story about when I first came here and the liver transplant program. I may have told this to you already. So when when I came here early in the 90s, we did not have a liver transplant program. One of the reasons I was recruited is because I had done some in my residency and fellowship in Chicago. So when we came, we had nothing. The only the only big program over here at that time was UCLA. So they decided to send us to UCLA to watch how they did a liver transplant. Not that we hadn't seen one before, but they felt it was a good thing to see how the competition was. Now, I went there, and the head person over there, I'm not going to mention his name, saw us, and he welcomed us from you, even though they were UCLA. And he said, you know, Rick is a nice guy. However, the USC program, that'll never take off. So 20 years later, and I think we're the biggest in Jehovah's Witness transplants, and we're probably close in number to what UCLA does. So each time I see Dr. X, you know, I remind him of that. And it's actually a tribute to Dr. Selby and then Dr. Jabor, who actually started the program over here. And I remember we started the transplant program, and then a few years later, we actually did cadaveric liver transplants. We actually started it. And, you know, at the time, on Jehovah's Witnesses. And at the time, it was very novel. No one was doing that in the community. UCLA, no one around the country. We were actually one of the first, if not the first, to do cadaveric liver transplants. And we did it, and Dr. Selby mentioned the success rate, or the limited success rate that we did. But we did it. And now we do mostly living-related donors for the Jehovah's Witness population, and we're very successful at that. But it was a true trial and error period during that time. And one of the mainstays during for doing cadaveric liver transplants was A&H. And I'll get to that in a moment. But I'm going to start a little bit. And since it's a small group, just feel free to interrupt if you have questions. All right. Let me see. How do you... I can't see that well. Oh, okay. I have no... Just click it. Okay. Yeah, there's no disclosures. And by the end of this, our objectives, just to understand a little bit about preoperative management on the Jehovah's Witness patient and what we do in anesthesia to make that happen. Okay, these are the blood components. I'm sure everyone has seen this slide before. And what we deal with is the fractions over here in the Jehovah's Witness population. And we deal with that, and it's a matter of conscience with most Jehovah's Witnesses, and we ask them before what they will take in that area and what they won't take. And that may determine whether we can do a surgery or not. So if we're doing a liver transplant and a Jehovah's Witness patient may refuse albumin, we may be limited in what we can do with a liver transplant. But we have a discussion about that way in advance. Okay, where do we start? This is even before we go to the operating room. I think it's important that we have to think about the surgery, not the day before, not a week before, not even 2 weeks before, but like 2 months to 6 weeks before. We have to try and evaluate the patient, if it's possible. And what we do is we need to see if we can increase the hemoglobin at that point in time, depending on how big the surgery is. So, for example, if it's a liver resection, yeah, we need that lead time to try and increase the hemoglobin levels to make sure that we have a high enough level if we're going to do ANH, for example. And I think Rick touched on this a little bit. You need a high enough level to do ANH. So if you're going to take off 2-3 units of blood, you can't start with a hematocrit of 25. You need at least in the 40s to try and do that, or a high 30s to try and get as much blood off as possible in case there's going to be a big blood loss surgery. And again, depending on what surgery, that's how we deal with the ANH. And I heard that question right before. That was, I think, the last question I heard. So we need to do that. And again, what's the reason we do it early? In case we have to give erythropoietin. We need about 6 weeks, 4 to 6 weeks to try and bring up the level with erythropoietin. And if we can do it with IV iron also to supplement that. But again, the important thing is timing. I think this was touched on also. Meticulous surgical technique. When we're operating, you always need meticulous surgical technique, but it's especially important in the Jehovah's Witness population where every red cell counts. And we need to see what type of surgery it is. The bigger the surgery, the more planning we need. And it has to be an interactive conversation with the surgeon, patient, anesthesiologist to actually have a plan of what to do. Because there are many surgeries, for example, if we're doing spine surgery, we don't have to do it all. And if it's going to be a more involved blood loss surgery, we can do the surgery, but it may not be all in one. It may not be an all-in-one operation. It may take 2 operations, and that's what we call staging. And again, meticulous surgical technique is important. Not that any other surgery you don't need meticulous surgical technique, but again, with bleeding, it becomes very important, especially when we're not giving blood. Okay, and again, minimizing intraoperative blood loss. There are some techniques that we do. So for orthopedic surgery, for example, if we're doing a total shoulder and there could be some blood loss, we may elect to do a regional technique where we can do it under a block as opposed to general anesthesia. And it's been shown in some of the studies that the blood loss is actually less with regional anesthesia than with conventional general anesthesia. So again, depending on what type of surgery it is, we may elect to use a different type of anesthetic to minimize blood loss. But all these considerations have to be taken into account. And again, the important thing I'm going to emphasize is communication. Again, between the patient, surgeon, anesthesiologist. That needs to be communicated. When this happens occasionally in a hospital, this happens. patient comes in, not over here because Randy is very good about screening the population, and generally we know about it. But when someone comes in for a big surgery in the morning and we haven't heard about it and we haven't planned for it, that can make the difference between actually doing the operation versus not. So again, communication, again, with the type of anesthetic. Okay, now we're going to talk about, acute normal volemic hemodilution, and we're going to see if my demonstration over here is going to be successful. And why should we use ANH? So the concept is that we actually take off blood from the patient, the concentrated blood in the patient. We take that off, and what we do is we replace the volume that we took off with either crystalloid, such as normal saline, lactated ringers, or colloid, such as heather starch, and those that actually accepted albumin. Crystalloid, we use approximately a 1-to-3 ratio, and with heather starch or albumin, it's approximately 1-to-1 ratio that we replace with the volume. And the theory is that when you're bleeding, you're going to bleed a more dilute blood, and at the end of the case, you infuse what you took off. Now, I'm going to show you the technique that we use over here, and the important thing is that we keep it in circuit, just like we do with cardiopulmonary bypass or with cell salvage, and we'll talk a little bit about that later. So the important thing is keeping it in circuit so everything is continuous over here. So I'm going to try to demonstrate this without making a big mess for housekeeping later on. Okay? And if you have any questions and you can't see, just let me know. Okay? Okay, I'm going to start this. Give me a second. Okay, first, maybe. Yeah. What?
You gotta wait?
Yeah, sure. Okay. Here, this is our Cpd bag. This actually is what the blood infuses into. And this is the bag that we collect the blood. It has a preservative to keep the blood for many hours. And we keep this in line with the patient. Okay.
Come on, this
Yeah, this side is probably better. Okay, this is the, be careful. This actually represents the patient. I made up this mixture this morning, and if it gets over the place, it's gonna, yeah, you know what this is. Okay, so what we do over here is we put this to grab, so this is the patient. It's much easier with a live patient in this. And, yeah, tangle. Okay, we can put that down. So, what we're going to, yeah, like I said, with a central line and a regular patient, with a big IV in a regular patient, much easier. Let's see if this, oh, okay. Does everyone see? Yes. This would be the blood. And we try not to put it on the floor. I mean, don't tell the Joint Commission that we're putting a bag that collects blood on the floor. We actually put it in a cooler box when we're doing this. So we actually, this would be the patient's blood actually infusing into this Cpd bag. And I'm going to try and squeeze it a little bit. Yeah, no, you see, if I was really, I'd put it in here. But yeah, and as you can see, this is draining out into the, into this bag and remaining in line with the patient. Okay, because that's important.
Do you adjust the rate at all during the operation?
The rate is the rate of this?
Yes.
I can't, this happens by gravity. So the pressure of the patient and gravity will determine how, and the bore of the IV that the blood is returning to the bag. I can't adjust the rate unless I increase the patient's blood pressure for some reason, or it goes by gravity. And that's how it goes. And again, the only thing that really adjusts is how big a IV I do it with. If I do it with a small catheter like this, it's going to take a while. If I put a big, what we call a central line in the patient with a big 14 or 8 gauge IV, that's pretty big, that'll go much quicker. But I didn't have any volunteers who would let me put in that. Yes?
How does the effect of regional versus general anesthesia affect the blood loss?
That's a good question. Regional, it's because the patient has less hemodynamic changes with regional. There's less blood loss and there's less vasodilation with regional anesthesia. More so with general anesthesia, and therefore you get a bigger blood loss. Again, the mechanism isn't that well, but that's the theory behind it. Okay, so is it? I think this is enough. We don't want to drain. So again, there was a question. I don't have a clamp. Okay. So what we do now is, now that there's a blood loss occurred during the case, I'm going to put the patient back down over here. So now that blood loss occurred during the case, what we can do is reinfuse. Now there was a question asked, how much blood loss occurs? When do we do ANH? How much blood loss should you have when you're doing that? And that should be about at least 1,500 cc's. Because if someone loses a liter, I don't know whether you have to go through all of this. Well, let me just talk a few more points. Yeah, that's fine. You're good. You're good. Okay. Let's see. How come this? You know, yeah, but I can't see. Is this? Okay. Yeah, my eyes. You know, old age. Yeah. So just to go through. So let me give you the pluses and minuses of ANH. ANH is good because you can give, it has the same, as opposed to bank blood, it has all the components in it. It's basically whole blood. So it has platelets, has plasma, has all the fibrinogen and everything, the clotting factors. So that's one of the advantages of using ANH. Also, you don't have to send the blood to the blood bank for testing. Bad thing is, once we take out the blood, we have to give it back to the patient. It does not leave the OR. It reinfuses, and that's just for safety's sake over here. We don't want it to get mixed up with any other blood. Again, it doesn't have the same tags that a bank blood from the blood bank has, so we try and reinfuse it in the OR. And bad thing is, it may have to get wasted if we don't use it. It can be given back right away to the patient. And we keep it in a cooler so we have at least 4 to 6 hours with the blood. Yes? No, I mean, it's still whole blood, it's still preserved. Even the platelets, if we don't put it in a cooler right away, the platelets will be preserved also. Where? Oh, yeah. Oh, we have a cooler. Beyond 4 hours. We can keep the blood for 6 to 8 hours. It's easy.
So what would be some reason to not take the blood back?
Clotted. That would be one reason. And like I say, not everything works as easy as this. You know, sometimes when we're taking out blood from a small bore IV, sometimes you can wind up with clots in the blood. And that would not be a good reason to give it back. Or if the blood, if the surgery goes too long and we feel that there's, you know, we kept the blood out too long, we can't give it back. But generally, we can give the blood back. But clotting is one of the more frequent complications because every time we take out this bag of blood, we have to agitate it and make sure that it it goes okay. The other good thing is, the other advantage, and something you can't always do with cell salvage, there's a big controversy on malignancy. So if the patient has a malignant tumor, with cell salvage, not everyone is agreeable to use that technique for the risk of shedding cancer cells. So with ANH, though, if you take blood out that way, there is not a problem in reinfusing it in someone who has malignancy. All right, now I'm going to show you okay, and again, I mentioned some of this, that the blood loss should be significant. So if someone's having a hernia operation, we should not do ANH because the blood loss is very insignificant. If there's going to be very significant blood loss during a hernia operation, I might get a different surgeon. But I wouldn't. Yeah, I've never seen a hernia operation where we needed ANH. Yes. So the diluted blood could cause increase in clotting because it's diluted depending on what the patient has. So one other thing that I need to mention is that if a patient has a clotting abnormality, to your question, you should not do ANH. If they're either hypercoagulable or a patient is not coagulable, you should not use ANH. If he has a hemophilia, for example. And again, these are some of the surgeries that we use ANH on: radical prostatectomies, hips and knees, elderly patients without cardiovascular disease, spine surgery, liver resections, liver transplants. Yes?
So you mentioned earlier that obviously you have to be fluids when you take blood out, and some of those fluids will be colloids or also albumin. What is the difference or the risk and the benefits of albumin
versus head of starch? That's a good question. So you cannot give too much head of starch because that can cause coagulopathies. If you give more than 1,500 cc's of head of starch, you could start making the patient bleed a little bit more. Albumin is a little safer in that respect. That would be the on that. Again, yeah. So anyway, let me show you how the blood is reinfused. Can I get my volunteer? Yeah. Can I get your assistance? Yeah. Thanks. Okay, we're gonna.
That's what a chief medical officer.
Yeah. Okay. What's yours? We're gonna. Oh. Yeah, we're gonna actually try to reinfuse the blood. So I'm gonna let it. If you want. The patient can be lowered. Actually, I put it on the table. Here, 1 second. Okay. So when we give the blood at the end, I don't think you can see the flow as much, but if we squeeze, you can squeeze. But be careful, not too hard. So this is actually reinfusing into the patient, and again, the blood has been in circuit the whole time. And again, it's connected to the IV over here, so we can actually bolus fluid. I apologize, I don't have better color indicators for this, but this is it flowing?
Yes, it's flowing.
Yeah.
For those of you who can't see it, you can actually see a swirl of the fluid returning back into our fluid patient.
So there were no valves turned or anything?
No, actually the valve was kept, it's in the different, it should be in the other position, but that's fine. The valves stay consistent throughout the case. I just wanted to talk about, anemia, and I think Dr. Selby touched on it. So when can we do this? Again, if the patient is too low, if his hemoglobin is below 40/35, we're not going to do ANH. And again, we wait a few weeks if we can to increase the hemoglobin. And again, at USC, we started a pre-op clinic, and eventually we're going to start making sure that we can give iron and treating anemia, especially for the Jehovah's Witness patients on that. Anyway, while this is flowing in, we're almost, oh, okay, so it's very easy. Yes?
Question, how much folate do you give to try and raise red cell mass? Because you said that earlier in the slides, you use a combination of IV iron, folate, B12. What milligrams do you use in terms of those products that you've seen good results?
We give a combination, and I don't remember the exact milligram dosage that's given in the clinic, but I'll get back to you on the exact dosages we give. Oh, yeah, that's okay. So now we're done, and I think we're good. And so this is the patient at the end of the case, and he's got a full volume of blood now, non-dilute. One other thing I wanted to touch upon. It's a little bit different. It's called acute, not normal volemic, but hypervolemic hemodilution, which we don't use, and that's just giving extra fluid into the patient. And the problem with that is, even though we don't need an elaborate setup for that, we just infuse more crystalloid or colloid into the patient. The problem with that is that can cause increases in different pressures. So the more fluid you wind up with an increased state. And if they don't bleed right away, you can cause high blood pressure, hypertension, cardiac failure with that technique. And that's why it's not used, and that's why the acute normal volemic hemodilution is used. So I think, is my time, do I still have time or? Okay, good. Yeah, so, and that's that's why we don't use it, even though there doesn't have to be continuous in-circuit with this. Cell salvage, I think we spoke about that again. During an operation, the blood cells the blood loss is suctioned into a container, and the loss is washed, and that's reinfused into the patient. Again, the bigger problem with that is malignancy. So if you're doing a cancer operation, you won't do that. You won't use that technique. Any questions on? Yes. We use this a lot. So yeah, during a liver transplant, you're going to have the cell saver people on one side. You're going to have the anesthesiologist doing A&H, and and we do that again to be cautious, especially in a bigger blood loss case. We want to be able to use every single red cell we can. So yeah, it's a lot of equipment in the OR. Yes.
Process of drawing the thing where you off as a part of or prior to using the blood.
So you're talking about drawing the blood off the patient?
You put the thing to replace the blood that first it off, but you have to keep it normal, and you have to pull that back off and reinfuse the blood, right?
We have an IV. Okay. We have an IV going into the patient continuously during that time. What we do is we put a big volume, we put that replacement volume at the beginning of the case. After we take off the blood, then we reinfuse that, depending whether it's crystalloid out or colloid, into the patient. And that stays in the patient. And then there's a continuous fluids that are going into the patient at that time. And again, it depends on how much blood loss is happening during that period of time. And depending on the blood loss, we'll actually make a decision when to reinfuse the A&H blood.
So there's no need to draw off any replacement fluid before you infuse it?
No. Okay, and that leads to, and I understand the point. So the point is, let's say you do A&H, and the patient doesn't bleed for some reason. You may elect not to give back the patient his blood, okay? Because, and the reason is because the patient may get too hyperdynamic. The patient may have too much volume. And at that point, there's nothing you could do about it. Sometimes we get lucky. Sometimes we take off blood and the patient doesn't bleed. It happens. And then, so what do you do with the A&H? If you think it's safe, you can actually give back the blood. If not, then it just, it may get wasted. Okay. Yes? Uh-huh. We use leukocyte reducing blood filters. However, even with the cancer, there's still controversy about giving back malignancy, whether the filter will work or not, or whether any filter will work with those cells. Yes.
Some doctors don't sufficient use cell salvage.
Fortunately, we don't do labor and delivery at this hospital. So, and again, that's because they're worried about infection and other things with cell salvage, amniotic components going into the patient. Yeah, so that's a controversy with cell salvage, again, with OB. But again, those are some of the issues with it. Again, malignancy in OB patients. Some people will not use it on that. Okay, let's see if I have any. Yeah, that concludes the lecture portion. Any other questions I can answer? Yes.
Just that one more question on the process. Do you feel it's safe to reinfuse the A&H blood, all of it? In order to prevent hypervolemia, do you use diuretics? How do you get rid of excess fluid, or do you even need to?
It depends. So if there's a significant blood loss during a case, we don't need to use diuretics. And again, depending on the patient's status, on his renal function and what the surgery is, we may or may not use diuretics. And that would be if we're getting a lot of fluid during a case, patient's bleeding, we're doing a massive resuscitation, we may use a little diuretics, even though it's counterintuitive, to make sure that the kidneys are working and that the patient doesn't build up a hypervolemic state or where the hypervolemic state, where the fluid would go into the lungs. That's why we use a diuretic. But in regard to giving back the blood, we wouldn't use a diuretic just to do that. Yes?
Is age or general health factors?
It's more general health factors. We go to physiologic health. So if a patient is 80 years old, has a good heart, no recent myocardial infarctions, we can do A&H. If someone is 50 years old but has a very bad heart history, has angina, has compromise of the heart, we won't do it. Because they need, that's a very good point, because they do need, in order to do A&H, they do need to be able to sustain a lack of oxygen. And patients with significant cardiac disease do not tolerate low hemoglobins or hematocrits. So, and we won't, especially acutely. Chronically, they may adapt, but acutely, where we're doing it in the OR, may be a problem. Okay. Thank you, everybody.